cyst, right? Now, so take a detailed history, then you have to go ahead with the physical examination, and then ultimately next step, as the third step, will be to go for an ultrasound. So whenever I find an adnexal mass in a reproductive age group women, I'm not too bothered. I'm like, okay, it is likely to be benign. Anyways, incidence tells me that most of the masses in the reproductive age group are anyways benign. But if adnexal mass in a young girl, perimenarcheal, if there's an adnexal mass in an 8-year-old, 10-year-old, 12, 13-year-old girl, then I'm like, no, this is significant, right? So this could be possibly malignant. Or if there is a adnexal mass in a postmenopausal woman, then also it is likely, then also the risk of malignancy is far higher. So in the reproductive age group, only about 7% are going to be malignant, whereas in postmenopausal women, about 30% masses are going to turn out to be malignant. All right. Now, what are the symptoms of the woman? Symptoms of the woman will also point towards something. The benign masses, they can be associated with pain. Didn't we see corpus luteal cyst? Didn't we see inflammatory tubo-ovarian masses? So what is the antecedent history? That is very, very important. Is she complaining of pain? Is she complaining of pelvic pain? Is she complaining of discharge per vaginum, which could point towards a PID? Is she complaining of dysmenorrhea? Is she complaining of features of infertility? That factors, you have to backtrace the history to these factors here, right? So you have to understand that evaluation of a adnexal mass is going to undergo, you have to take a very good history also. So you have to evaluate, backtrack these in history, whether there is a history suggestive of endometriosis. Is she pregnant? Could that be the reason, right? Did she have a molar pregnancy? So these are the kind of things. Or again, relationship to the menstrual cycle also could be a corpus luteal cyst, or history pertaining to inflammatory diseases like PID and genital tuberculosis. So that becomes important, right? So antecedent history, what is the history, what is the symptoms, that becomes important. Now when the mass is malignant, they are usually painless to begin with. Malignant masses are characteristically painless, right? Then we go for the physical examination. What is a physical examination? Now again, per speculum examination and per vaginal examination, right? So let's say there is this uterus and there is this ovarian mass. Okay, and I want to tell you that this ovarian mass is nothing but a cyst. This ovarian mass is nothing but a cyst. Now this cyst, this follicular cyst, which is most commonly seen, is just containing of simple serous fluid, Now when you will do a PV examination and try to palpate this mass, you will see that it is a cystic to feel, it is freely mobile, it may be tender if it is an inflammatory mass, and most of the times it is going to be unilateral rather than bilateral. But if you are evaluating an adnexal mass which is likely malignant, malignancies are characteristically solid to feel, hard to feel, they are non-tender, they are fixed to the underlying structure, so the mass will not be mobile, and they are usually bilateral. So any bilateral mass, solid mass, hard mass, a single ovarian mass here, and it is filled with just anechoic. This darker area is anechoic, right? So this is an anechoic unilocular cyst. Yeah, so this is an anechoic unilocular cyst with posterior acoustic shadowing. This is the posterior acoustic shadow, that is caused by the serous contents of the cyst. So if this is the appearance of the cyst, I'm almost 100% sure that this is nothing but a benign follicular cyst. Okay, And then we can have this kind of an ultrasound appearance where there is a huge cyst, okay, huge ovarian mass, and you can see how there are septations, how the ovarian mass is divided by septation. So it is multilocular, these solid areas inside the mass are there. So all of these features, they raise the suspicion of malignancy. All of these ultrasound features, they raise the suspicion of malignancy. So what are the ultrasound features here? There can be bilateral masses, multilocularity or septations like you are seeing in the ultrasound picture here, presence of solid areas, presence of ascites in the abdomen and the pelvis, metastatic deposits nearby, right, or any enlarged lymph nodes is there. So these will raise the suspicion of, these findings will raise the suspicion of the mass being malignant, right? So as long as the mass is typically looking benign, the management can be conservative, right? One thing is that. But the next important thing is the size of the mass that we have to consider. If the mass is too big in size, what is the potential complication? If the mass is too big in size, the potential is a torsion, like Uja was pointing out. So you realize here, infundibulopelvic ligament, that is connecting the ovary to the lateral pelvic wall, right? Now the ovarian artery that is supplying this ovary is coming to the ovary through this infundibulopelvic ligament. Now when this ovary twists around its pedicle, it twists around here. So there is twisting, and that leads to compromising of the blood flow to the ovary, because the ovary is getting supplied through this infundibulopelvic ligament. So there is ischemia, there can be necrosis later on inside the ovary. Now this is an acute condition. This is what is called as ovarian torsion, and this ovarian torsion is now a surgical emergency, because obviously the ovary is getting test. So it has been seen that the risk of torsion is more there, and the possibility that there could be an underlying malignancy is also more as the size of the mass increases. So if the size of the mass is more, is suspicious with features of malignancy, or we don't know whether it is an ovarian cyst, okay, if the size of the ovarian cyst is more than 7 centimeter, that is one indication. But if we are not sure whether it is coming from the ovary or tube, and the whole adnexal mass is more than 10 centimeter, that is another indication to operate, right? And the other thing is, whenever there is features of acute abdomen like torsion, okay, features suggestive of torsion, acute abdomen, then these are also the indications to operate. So one of the indication to operate is size of the cyst, right? Or the second indication is that you were doing follow-up but the size is now increasing, or the ultrasound is suspicious. And in the ultrasound being suspicious, there can be multiple factors, okay? So bilaterality, multilocularity, septation, solid areas, right? All those go in favor of suggestive of malignancy, and then it should be operated, likely to be, it should be operated, right? Now, the other thing to note here is, what is the surgery done in the reproductive age group? Now, in the reproductive age group, since most of the times the masses are actually going to turn out to be benign, the surgery that is done is, see, this is an ovarian cyst, okay, this is the ovary, this is a cyst inside the ovary. This here is showing the cyst inside the ovary. This is the thing that is being peeled off. This is the ovarian capsule. This is the ovarian capsule that is being peeled off to reach the ovarian cyst, and we will take out this cyst, scoop this cyst out. No need to remove the entire ovary if the cyst is benign looking. So that is a, let's say there was a unilocular cyst which was measuring more than 7 centimeter, and I decided to operate on it. What is the surgery that I'm going to do? What is this surgery called? This is called as, rightly said Uja, it is called as cystectomy. It is called as cystectomy. Just remove the cyst. And for histopath, and then the histopathologist will give me the final diagnosis whether it is benign or malignant. Okay. Now, what about adnexal masses in pregnancy? Size being more than 7 centimeter, features of torsion, ultrasound suspicious, and everything. The indications of operating are the same, but I want to know, I want to ask you this, I want to think, why to operate in pregnancy at all, right? And it does fulfill the indication of getting operated, but why do I want to operate it in during pregnancy? Can't I just let her finish off her pregnancy and operate after she's done with her delivery and everything? Why do I want to operate in pregnancy at all? Well, I want to operate in pregnancy because this is a big cyst, right? So it might interfere later on during labor. All right, it might interfere with the descent of the presenting part. So that is one possibility. The other major possibility actually is that the risk of torsion increases. Yes, Uja very rightly said, prevent torsion and labor dystocia. So risk of torsion increases in pregnancy. And why does the risk of torsion increase in pregnancy? Why does the risk of torsion? So you see, there are two times when this risk of torsion is particularly high in pregnancy. See, this is the uterus right now, 3 month. Okay, let's say this is a 3 month uterus. This is the ovarian mass here. Okay, there is a pregnancy inside. This is 3 month. The moment she will become 20 weeks, there will be this increase in size of the uterus, right? There will this be increase in size of the uterus from 12 weeks to 20 weeks, right? That is when this dramatic increase in size takes place. So this is one risk period when the uterus operate right now. I'm going to operate if at all the indication is fulfilled. The indications are the same, but if you have to operate, you will operate at 16 to 18 weeks in the second trimester. Do not touch in the first trimester, right? Because when we try to operate these adnexal masses in pregnancy or outside pregnancy, obviously we have to give some sort of anesthesia. If we're going to go for laparoscopy, we have to give a general anesthesia, so that the risk of complications to the fetus are also there with anesthesia, and they're particularly more in early pregnancy. So it is safer to operate at 16 to 18 weeks time, right? Emergency, then doesn't matter what gestation she is, you have to operate immediately. Then you have to operate immediately, because torsion is menopausal women is very, very suspicious, right? So is there a marker of malignancy, any tumor marker that you know of that can help in the evaluation of a postmenopausal woman? Laparoscopy is preferable over laparotomy. Laparoscopy is safe even in pregnancy. Okay. Now, management of adnexal mass in polls, right? So CA125 is cancer antigen. Now, what is this CA125? Well, this CA125 is a marker for epithelial ovarian cancer, right? Only for epithelial ovarian cancer. There are many cancers, many histological type of ovarian cancers, which I'm going to discuss next. But CA125 is only a marker for the epithelial ovarian cancers. It is raised in 50% of early stage cancers and in about 90% of advanced ovarian cancers. So it's a good marker. But can you tell me, why am I using it only in the postmenopausal women, and why am I not using in the reproductive age group? If there is a marker for epithelial ovarian cancer, very, very less. Specificity meaning that if I do a CA125 level in a reproductive age group women, it might come positive many times and it might not mean anything. Why? Because there are many conditions which are common in the reproductive age group which are also associated with raised CA125 levels. So CA125 levels is not very specific for malignancy in the reproductive age group, because CA125 is also raised in conditions like endometriosis, genital TB, PID, fibroid, adenomyosis, right? So that is why the utility of doing CA125 is not much in cyst, that anechoic unilocular cyst. If all of these are present, then only we can observe the woman and we might choose not to operate. But if at all she is symptomatic, If the size is more than 5 centimeter, equal to 5 centimeter, if there is raised CA125, if they are bilateral, or if there are USG findings which are suspicious of malignancy, if any of this is present, then no conservative management is possible. We have to remove the mass with surgery. So there's a 56-year-old woman who complained of pain in the lower abdomen and on ultrasound showed a 4 centimeter but bilateral ovarian masses with increased cancers and malignancies. There is angiogenesis, right? Even you have this pathology, you've read angiogenesis with malignancy, right? So the vascularity of the mass is more in cases of a malignant mass. So what is the next line in management? Is it ultrasound guided biopsy, wait and watch, surgery, or OC pills? Very good, it is surgery, right? Very good, it is surgery. Now, ultrasound guided biopsy, no, we are not biopsying the ovarian mass under any circumstance. Immediate removal. If we will go for an immediate removal. And it also contains the germ cells. So any of these elements can give rise to malignancy. So ovarian tumors can be epithelial, can be germ cell tumors, or they can be sex cord stromal cell tumors. Remembering the histology, see, I did not focus much on the histology in cervical cancer or in endometrial account for about 5 to 8 reproductive age group. This is a part of the reproductive line. So benign tumors are more common overall than malignant tumors. So if they ask you what is the most common, adenocarcinoma. That is the most common type of ovarian cancer. Again, cyst, which is the most common ovarian tumor in the reproductive age group. Right, so these are plus malignant. So obviously the benign is more common. So the most common germ cell tumor is a dermoid cyst, but the most common germ cell cancer, if they ask, then that is a dysgerminoma. That is a dysgerminoma in routine clinical practice, right? So this is also called as a mature cystic teratoma. Now, if you remember this name, you will remember what goes on into a dermoid cyst. Mature cystic teratoma. Cystic is because it feels cystic. It has a cystic feel to it. It contains a cystic fluid inside. Teratoma are tumors which contains the embryological elements from the germ cell layers, and those embryological remnants are mature. So presence of mature tissues which are derived from all the 3 germ cell layers, all the 3 germ cells, that is 3 germ layers, that is going to be there in a mature cystic teratoma. So you can see here on the inset this picture. This is an ovarian cyst, which is a dermoid cyst. The lining of the cyst is epidermis, right? The lining of the cyst is epidermis, stratified squamous epithelium. Then what is this foci called? What is this foci called here? Histopathologically, this is called as the Rokitansky protuberance. This is called as the, look at this appearance and then compare the ultrasound findings. You see here, this is a cyst, again an ovarian cyst here, which contains some fluid material. You can see these fine strands of hair, and this is the protuberant area there. This is the rock solid area inside. Now this is a classic dermoid cyst. And we can see the same Rokitansky protuberance here. And you can see that there are dashes and dots on the cyst. This is called as the dash and dot appearance. That is because of the fine strands. All of these germ cell cancers, they are going to be more common in the reproductive age group anyways, right? In the reproductive age group. Right now, the tumor marker for dysgerminoma is LDH mainly, but yes, we can also see raised levels of placental alkaline phosphatase and HCG as well. All of these germ cell cancers are mostly unilateral. All right, what is Meeks syndrome? What is Meeks syndrome? Meeks syndrome is a syndrome that is comprising of fibroma, ascites, and pleural effusion. Fibroma, ascites, and pleural effusion, this combination together is called as Meek syndrome, right? Then what is pseudo-Meek syndrome? There is a syndrome which is pseudo-Meek syndrome. Pseudo-Meek syndrome is the same association, that is ascites, pleural effusion, but with a histology other than fibroma. That is called as a pseudo-list. Most likely diagnosis: dysgerminoma, endodermal sinus tumor, malignant teratoma, mucinous cyst adenocarcinoma. Young female LDH raised diagnosis: dysgerminoma. Dysgerminoma. With endodermal sinus tumor, AFP should be raised. Malignant teratoma is the second most common and no marker is raised. No marker, specific marker exists. Mucinous cyst adenocarcinoma, look at the age. This is more commonly going to be seen in the elderly women, not in such a 20-year-old young female. Okay, so this is the kind of question that they ask. And last question for the day. Let's see who answers this. 26-year-old woman during workup of primary infertility is found to have bilateral ovarian masses. CA125 levels are 90. What is the most likely diagnosis? Endometriosis, genital tuberculosis, dysgerminoma, or fibroid? Have a look at the whole profile of the woman. 26-year-old, primary infertility, bilateral ovarian masses, CA125 levels are 90. Now normal CA125 levels are actually 35, less than 35 IU per ml. In cancers, the levels are usually more than 200. Okay, levels are usually more than 200. Now these CA125 levels are raised, but they are not very abnormally raised. What is the most likely diagnosis? Somebody answered endometriosis uja. What do the rest of you think? See, it's not fibroid. Okay, dysgerminoma, it could be a bilateral dysgerminoma, but you know the incidence of bilaterality is very, very less, right? So, and if they would have wanted to give you dysgerminoma as the answer, they would have said raised LDH, right? Shrigiri is saying genital tuberculosis. I agree with you, Shrigiri, that there could be, both could be the possibility. Both are equally possible. Both are equally possible. But why I will choose endometriosis as the answer over genital tuberculosis is because endometriosis is more commonly associated with bilateral endometriotic cysts. Bilateral endometriotic cysts, and with genital tuberculosis, the least common granulosa cell, Leydig cell, dysgerminoma. Dysgerminoma, age not going hand in hand. Age is 45. Leydig cell tumor, features of virilization will be there. Abnormal heavy bleeding. Granulosa cell tumor, Shrigiri. Look at the age, 45-year-old. More fitting into this description of sex called stromal cell tumor, granulosa cell tumor, abnormal heavy bleeding. This tumor secretes estrogen, right? So these are the kind of questions that they ask you. They give you a profile, they want